Hello friends, I am Dr. Farheen, your OBGY faculty at Aakash PG Plus. Along with my colleague Dr. Shefali, I will be discussing the INICET previous year questions along with the high yield topics. Each question has been segregated into various OBGY topics so that your preparation is structured. I have tried to keep the explanation short, crisp and very informative. So let's start the INICET Premier League 30-30 where we will be discussing 30 questions in 30 minutes. So the time starts now. What is the earliest sign of intrauterine pregnancy? The earliest sign is the intradecidual sac sign. So as the name suggests, this is the uterus, this is the decidua and there is a sac inside the decidua. Okay. There is this another sign, the double decidual sac sign or the rim sign, where we can see two rims over here. The outer is formed by the decidua capsularis, the inner is formed by the decidua parietalis. However, this is not the earliest sign. What is the most confirmatory sign of intrauterine pregnancy? Then it is the presence of the yolk sac. This is a double bleb sign. We can see a gestational sac over here. The first sac is your yolk sac and the second sac is the fetal pole. Also, let's see the chronology of events which appear in fetal imaging. The mnemonic of this is Guy Pass. So the gestational sac appears around 4 to 5 weeks on the TVS, yolk sac around 5 to 6, you just need to add 1 week to everything, fetal pole around 6 to 7 and amniotic sac around 7 to 8 weeks. If you were asked on a transabdominal sonography, then to all of this you add plus 1 week. At what time is the cardiac activity seen earliest? So it is around 5 weeks. Another common question is, what is the value of beta HCG at which the gestational sac can be seen earliest? So on the TVS it is seen around 2000 international units of beta HCG and on transabdominal sonography the value is 6500 international unit. Alright, so this is your answer. Going to the next question, a patient presents in the OPD with pain in abdomen, she has missed her periods and this is the ultrasound finding. So this is a typical ring of fire or the donut sign or the Bajal sign, and this is seen in your ectopic pregnancy. It is also seen in a corpus luteal cyst. The fourth question is, what is blighted ovum? So blighted ovum or an embryonic pregnancy has two definitions. The first is when the mean sac diameter or the gestational sac is more than 25 millimeter. This is more than 25 millimeter, but there is no yolk sac or fetal pole. Again, what was the chronology of events? Gestational sac followed by yolk sac, your fetal pole and then your amniotic sac. So the gestational sac has appeared. It is more than 25 millimeter, but there is no yolk sac. The second definition is that the crown rump length, okay, from the crown to the lump, this length is more than 7 millimeters, but there is no fetal heart rate. Okay. Now coming to the fifth question, a patient presents to the OPD, she has a previous baby with Down syndrome, which is the test which has the highest detection rate. Okay. She has presented with 12 weeks of period of gestation. Another question, what are the components of the dual marker? Okay. Let's see what are the tests in prenatal genetic testing. It is tested in the first trimester and second trimester, and in each trimester we are doing a blood test and a ultrasound. So the blood test of the first trimester is known as the dual test. Here we are assessing two things, PAP-A and beta HCG, and on the ultrasound, which is also known as the level 1 scan, we are testing the nuchal translucency. So for the nuchal translucency to be tested, the crown rump length should be around 45 to 84 millimeter. What is the nuchal translucency? It is the collection of fluid behind the nape of the neck over here. So we can see that this is normal, okay, but this we can see that there is a lot of collection behind the nape of the neck and this is abnormal. Okay. What is combined test? When we combine the blood test along with the ultrasound in the first trimester, it is known as the combined test. So again, what were the components of the dual marker? A and B. A is your PAP-A, B is your beta HCG. In the question, she has come on 12 weeks, okay. So she is in her first trimester. Which is the highest detection, which has the highest detection rate? So dual marker has a detection rate of 70%, whereas combined test, when you combine dual marker along with the ultrasound of nuchal translucency, the detection rate becomes 80%. Okay. Why will quadruple marker not be an answer? Because quadruple marker is done around 15 to 18 weeks. Okay. And what is integrated test? Integrated test is your first trimester test plus your second trimester test. Now the seventh question, the patient presents with a nuchal translucency of more than 3 millimeters, the baby can have all of the following except, okay. So nuchal translucency more than 3 millimeter or absent nasal bone, we need to worry that there can be aneuploidy. The most common of them is trisomy 21, okay, followed by the Edwards syndrome, followed by the trisomy 13. Then nuchal translucency can also be increased in the Turner syndrome or cardiac defects in the fetus. So therefore the answer of exclusion will be Klinefelter's syndrome. Question number 8, what does triple test assess? Now as the name suggests, the triple test is going to assess three things. What was dual test assessing? A and B. The triple test will assess A, alpha fetoprotein, B, beta HCG, and C, unconjugated estriol. What is quadruple test? Quadruple test is triple test plus inhibin A. So how do you remember that quadruple is inhibin A not B, because this they have also asked as a question. So in quadruple you have A over here and you have A over here. The ultrasound of the second trimester is known as the TIFA scan or the targeted imaging of fetal anomaly or the level 2 scan or anomaly scan, and it is done around 18 to 22 weeks. So this is what we will be assessing in triple test. Quadruple test assesses all of the following except. So A for quadruple, A for inhibin A. So therefore the answer will be inhibin B. Another question, which test has the highest detection rate for aneuploidy? Okay, so let's go through the options. What is combined test? Combined test is your dual marker plus your nuchal translucency ultrasound, right? What is your quadruple test? Quadruple test is you're checking your ABC plus inhibin A, right? And what is integrated test? As the name suggests, we are integrating the first trimester and the second trimester test. So it is the combined test plus the quadruple test. Now this, what is this NIPT? NIPT is the non-invasive prenatal testing. It tests the cell-free maternal DNA and it is just a screening test, but it has a very high detection rate, okay. So the detection rate of this is around 99%. And why has it gained so much of popularity? Because it is non-invasive and it is just done by taking the maternal blood. Howsoever, if the patient comes out to be positive on NIPT, then we have to confirm it by either chorionic villus sampling or amniocentesis, okay. So your answer would be NIPT. Now the 12th question, an 18-week second gravida presents to OPD with a Down syndrome cutoff of 1 in 200. What is your next management? Okay. So first of all, we should know what do we mean by cutoff of Down syndrome. The normal cutoff is 1 in 250. What do we mean by this? That a woman has one chance out of 250 that the baby is going to be Down syndrome. 1 in 200, what do we mean by this? That she has one chance out of 200 that the baby is going to be Down syndrome, which means that she is definitely at a higher risk than this cutoff. When she would have been safe, if it would have been 1 in 300 suppose, which means that she has 1 in 300 chance of having a baby with Down syndrome, okay. So that means she is above the cutoff. So right now she is within the cutoff. So what is your next step of the management? Do nothing as the patient is low risk? No, she is at high risk. Offer NIPT? Well, we can do this, okay. Let's keep this option as mine. Do amniocentesis? We can do this also. Confirm with level 2 scan. Well, level 2 scan is just an ultrasound scan, and when your blood test is showing that she is at a high risk, then we have to do something else. Now discussing about these two things. NIPT, we know that it has a very high detection rate, okay, right, 99% detection rate. But what does the question say? How will you confirm the diagnosis? Okay, so we are going to confirm the diagnosis by amniocentesis because NIPT is just a screening test. All right. So this is going to be our answer. That the prenatal genetic testing that we are doing in the first trimester, what are we doing? We are testing the dual marker plus the nuchal translucency. In the second trimester, it is either the triple test or the quadruple test plus the level 2 scan. Okay. So in any of these tests, if it says that the patient is at high risk of having an anomalous baby, then what is the confirmatory test which is going to clinch the diagnosis? So in the first trimester, the confirmatory test is your chorionic villus sampling, and in your second trimester, It is amniocentesis. Okay, so this is your confirmatory test. But which has the highest detection rate? Highest detection rate has NIPT, but this is also a screening test and it is not confirmatory. Okay. So chorionic villus sampling, it is done in first trimester around 11 to 13 weeks. It is not done before 10 weeks because it can cause limb defects and oromandibular defects. This is also a part of a question. How do we take the sample? We can take it transcervically also, and we can take it through transabdominal through the ultrasound guided. The cell sample is the trophoblast, and there is a 1% risk of miscarriage because we are doing sampling in the first trimester. Amniocentesis is the second trimester confirmatory test. The best time is around 15 to 20 weeks. It is not done before 15 weeks because there can be increased chances of miscarriage. How it is done? It is done abdominally only through the ultrasound guided probe. And what is the cell which is sampled? Now the cell that is sampled here is fibroblast and amniocyte. It has lesser chances of miscarriage, around less than 0.5%. Chordocentesis is generally done around 20 weeks. The sample is the fetal blood sample and the route is abdominal. Next question is match the following. So it's a simple question, but you just need to remember which drug leads to what. FDA has categorized drugs and medications as per the risk. So category A is that it has no risk to any trimester. B is that slight evidence of risk is there. C is that the risk can be present, but it somehow outweighs the benefit. And D is positive evidence of risk. X is contraindicated in pregnancy. So let's talk about few drugs which are teratogenic. Phenytoin can lead to fetal hydantoin syndrome. Your AC inhibitors and angiotensin receptor blockers can lead to fetal renal hypoperfusion. Alcohol can lead to fetal alcohol syndrome. Lithium can cause Epstein's anomaly. Indomethacin, if given after 32 weeks, can lead to premature closure of ductus arteriosus. Methimazole can lead to cutis aplasia. Warfarin can cause embryopathy. Thalidomide can lead to limb defects, phocomelia. Methotrexate can lead to cloverleaf skull defect. Your diethylstilbestrol can cause clear cell adenocarcinoma and T-shaped uterus in females, and hypospadias and undescended testis in male. Valproate can lead to neural tube defect, and it is the most commonest and it is the highly teratogenic anti-seizure drug. Chloramphenicol can cause grey baby syndrome or the peripheral vascular collapse. Okay. Now the patient presents to OPD with 3 recurrent abortions and in the first trimester. Okay. So we need to keep in mind 3 recurrent abortions in the first trimester. What is the likely cause except? So the most common cause of recurrent pregnancy loss in first trimester is your chromosomal anomaly, balance translocation. Other causes can be endocrine, anatomical, which are Mullerian defects. In Mullerian also the most common is your septate uterus. Okay. Then there can be immunological causes also. The second trimester loss, most common cause is cervical incompetence. They can be inherited thrombophilias and they can also be anatomical causes or Mullerian abnormalities. Okay. So cervical incompetence is your answer of choice because it does not cause RPL in the first trimester. Patient gives history of 3 recurrent pregnancy losses in the first trimester. What is the commonest cause? Commonest cause is your chromosomal abnormality. Then patient gives history of painless delivery in the second trimester. In her first pregnancy, she delivered at 28 weeks. Second pregnancy, she delivered at 24. Third pregnancy, she is delivered at 22 weeks. So here we can see that with each passing pregnancy, she is delivering earlier. What is the most common cause? This is the pathognomonic feature of cervical incompetence, where baby delivers early with each progressive gestation. The cervical length is less than 25 millimeter on ultrasound or less than 2.5 centimeter. There is painless cervical dilatation, there is no pain and bleeding. Okay. Now the next question, a 16-week second gravida, she comes with a history of previous preterm birth at 28 weeks of period of gestation. What are you going to do next? Going through the options, this is the question from cervical incompetence. Okay. So let's talk about first cervical cerclage. Cervical cerclage is of 3 types. The first is the history indicated when patient is giving you history. On the basis of the history, as per the new guidelines, they have divided patients into high risk or the intermediate risk. Okay, we will discuss them one by one. Second is your ultrasound indicated cerclage when the patient has no symptoms but her cervical length is less than 2.5 centimeter and we have to perform cerclage. Third is the physical exam indicated or the emergency and rescue cerclage. Okay, so first talking about the history indicated cerclage. So who are the women at high risk? We need to remember all of these points. Those with a previous preterm birth or a second trimester loss between 16 to 34 weeks, right? Our patient has a preterm loss at 28 weeks, so she is definitely at high risk. Then patient who had a premature rupture of membrane at less than 34 weeks, who had a previous use of cerclage, who has a known uterine anomaly, who has intrauterine adhesions, and who has a history of trachelectomy. Okay, so you need to remember all of these points. What are we going to do in these patients? Are we going to go directly for cerclage? No. There are very clear and strict guidelines that these women should undergo TVS from 16 weeks onwards till 24 weeks every 2 to 4 weeks. At any time in between this, if the on ultrasound it comes that the cervical length is less than 2.5 centimeter, then only we will proceed with cerclage. Okay. So what are we going to do in this patient? The next step is that we are going to do ultrasound in this patient every 2 to 4 weeks between 16 to 24 weeks. Alright. Talking about the intermediate risk patients, who are the women who are intermediate risk? Who have a previous history of a full dilatation cesarean section. It means that they were undergoing trial of labor, the cervix was fully dilated, however they could not have a normal vaginal delivery because of some reason. Another is who had large loop excision of the transformation zone with a depth of more than 1 centimeter and more than one procedure or a cone biopsy. So what are we going to do in these women? We will do a single TVS between 18 to 22 weeks at any, if on this TVS the cervical length comes out to be less than 2.5 centimeter, then we will go for cerclage. Okay, let's discuss the answer of this. How are you going to manage her? Do prophylactic cerclage? No, not right now. Start her on progesterone? No. Do nothing? No, definitely she is at high risk, so we cannot not do anything, right? And do serial ultrasound for cervical length. So yes, we are going to do this. Okay. Now a short trivia about other cerclages also. The ultrasound indicated cerclage is done when the cervical length is less than 2.5 centimeter. And what is the rescue cerclage or the physical examination cerclage? As the name suggests, that there is some emergency which is happening, right? We have to rescue the patient. So it is done in case of premature cervical dilatation in whom TVS reveals that the cervix is less than 2.5 centimeter. Until what gestational age can it be done? It can be done till 27 plus 6 weeks of gestation. Why is this the cutoff? This is cut off because beyond 28 weeks the fetus is going to be viable and we can go ahead with delivering the baby. Talking about viability, viability in India is around at 28 weeks and viability abroad is how much? 24 weeks. Okay. Now next question, second gravida at 18 weeks period of gestation. She gives previous history of a preterm birth of an anomalous baby at 28 weeks. What is your next step of management? Okay, so next step generally would have been an ultrasound to determine the cervical length. It has already been done over here and it shows that the cervical length is 2 centimeter. So what are we going to do now? We have to proceed with cerclage. Let's see what are the options. Wait and watch? No, we cannot wait and watch. Give progesterone? No, it is not going to solve the matter. Rule out fetal anomaly on USG? Well, this is a new option, let's think about it. And plan her for cerclage. Okay, definitely we can plan her for cerclage. So before doing any procedure, we should know what are the indications and contraindications. The patient is well fitting into the indications, but now what are the contraindications? This is the catch over here. The contraindication for cerclage is any rupture of membrane, any infection, any vaginal bleeding, or the patient is in active labor where the cervix has been dilated more than 4 centimeter, she is having uterine contractions, and fetal death or anomalous fetus in the present pregnancy. Okay. So in this question, she gives a history of a previous anomalous baby. We also have to rule out whether this baby is anomalous or not. Even if she won't have given a history of previous anomalous baby, we have to rule out fetal anomaly in the patient and we will rule out fetal anomaly on ultrasound. Okay. So coming to question 19, which is the procedure which is done in a non-pregnant female? Lots of fancy names are there. The cerclage is done by two methods, abdominal and vaginal. Abdominal, it can either be done by a laparoscopy or it can be done by a laparotomy. Okay. We all know that laparoscopy procedures are preferable to laparotomy procedures, right? So the laparotomy procedure is called the Benson and Fee, and the laparoscopic cerclage is there. In vaginal, we are familiar with two procedures, McDonald's and Shirodkar. They are a modification of this lash and lash procedure. Coming to the worms or the Hefner's procedure, so what are we doing over here? That this is the cervix. We are taking one bite at 12 o'clock position, another bite at 6 o'clock, and here at 3 o'clock position and 9 o'clock position, and this is how we are tying the cervix. So this is the faster method and this is known as the worms procedure. Ideally the vaginal cerclage is preferred, but when is the abdominal cerclage done? It is done when the vaginal cerclage has failed or the cervix is too short either congenitally or because of any procedure that the vaginal cerclage cannot be done. Okay. So the laparotomy procedure where we are giving the nick in the abdomen, it was developed by Benson and Fee. Both the abdominal procedures, Benson and Fee or the laparoscopy, they can be done in non-pregnant females and the stitch is placed at the high cervico-isthmic junction. Now what are the side effects? With the abdominal cerclage, the patient can only undergo a cesarean section. Okay, so the patient needs to undergo two procedures. One is for the laparotomy and another is for the delivery. Indications for laparoscopic cerclage are all same as the abdominal cerclage. It is less invasive than the laparotomy. What is McDonald suture? It is the vaginal cerclage. Purse string sutures are placed in the cervico-isthmus junction. Bladder mobilization is not required because the suture is placed at the lower level. The suture is generally non-absorbable ethylon, right? This is the suture which is used. So this is how we take purse string sutures. Shirodkar is a high transcervical cerclage. Since it is high, so the bladder can get involved. We need to mobilize the bladder. We are also using non-absorbable sutures here. Generally the Merceline tape is used. Okay. So coming to the question, which is the procedure which is preferred in a non-pregnant female? Non-pregnant female abdominal procedure is Benson and Fee and laparoscopic cerclage. But amongst these, which one will be preferred? Laparoscopic, because it is less invasive, right? Now the next question, a pregnant woman presents to OPD. She has a previous twin delivery. What is her parity index? So first let's discuss what is her parity index. Okay. What is gravida? Gravida is number of times the woman gets pregnant, including the present pregnancy. So she has been pregnant, this patient, for the second time. Alright. Parity, number of times the pregnancy has crossed the period of viability. What is the period of viability? 28 weeks, excluding the present pregnancy. Okay. So how many times has her pregnancy crossed 28 weeks? One time. Okay. We are not going to include twins as two. The pregnancy was only one, although she was bearing a twin, but the pregnancy was one only. So she is para 1. Living, the total number of children who are living as present. So she delivered twins who are alive and healthy, touch wood. So living will be 2. She has no history of abortion, so it will be A0. So this is what she is going to be. So this is our answer. Alright. So what is the minimum recommended ANC visit as per WHO? This is a very straightforward question. You know it, you know it. As per WHO, there are 8 visits, and as per Government of India, divided by 2, 4 visits. Okay. So first visit in WHO, in the first trimester 1 visit, in the second trimester there are 2 visits. Okay. And in the third trimester there are 5 visits. Okay. So 8 is our answer. All of the following vaccines are safe in pregnancy except. Okay. So let's talk about the vaccines which are given in pregnancy. Tetanus is generally given in 2 doses. The first dose is given around 16 weeks. The second dose is given 1 month after this, around 20 weeks. Okay. Tdap is your tetanus diphtheria vaccine. It is generally given around 28 weeks along with the influenza vaccine. Why is it given at this period? So that it protects the baby also when the baby is born. Anti-D prophylaxis is given to all women who are Rh negative and ICT negative also. Yeah, very important. Talking about the vaccines which are contraindicated in pregnancy, all live vaccines are contraindicated basically. Measles, mumps, rubella, varicella, BCG, all live vaccines are contraindicated, but there is a catch. 2 vaccines can be given. rabies and yellow fever if the patient goes in that endemic area. So going through the option, influenza, yes, it is given, Tdap, it is given, yellow fever, it can be given, but varicella is something which is contraindicated. Okay. What is the additional calorie intake of women in lactation and what is the RD of protein in pregnancy? This is a question which has been overlapping with your PSM also. So in pregnancy, a woman requires additional 350 kilocalories per day. In lactation, she requires additional 600 kilocalories per day if she is 0 to 6 months postpartum, and if she is 7 to 12 months postpartum, she requires additional 520 kilocalories per day. Okay. The RD of protein in pregnancy is around 60 to 65 gram per day. Which of the following is not a sign seen on clinical examination in early pregnancy? So let's go through the signs. Jacquemus or Chadwick's sign, it is a vaginal sign. There is bluish hue of the anterior vaginal wall, as we can see here that there is a bluish hue. Okay. Osiander's sign, increased pulsation felt through the lateral fornices. So these are the fornices, the lateral wall of the vagina, and we can see that because of increased vascularity, there can be increased pulsations also. Goodal sign is nothing but the cervix which has softened. Now what is Picasek's sign? Picasek's sign is that there can be asymmetrical uterine enlargement in cases of lateral implantation. Talking about the Hagar's sign, so on bimanual examination we can see that the abdominal and the vaginal fingers oppose below the body of the uterus. So this is your Hagar's sign. Palmer's sign is the regular and the rhythmic uterine contractions which are elicited on the bimanual examination. So this is generally on the bimanual examination. So which sign is not seen in early pregnancy? Goodal sign, which is the softening of cervix, it is seen. Hagar's and Palmer's is seen on your bimanual examination. Lambda sign is not seen in your early pregnancy. All are true about HCG except, okay. So HCG is produced by the syncytial trophoblast. It has two units, your alpha and the beta subunit. The doubling time in early pregnancy is 48 hours. The alpha subunit is similar to LH, FSH and THS. So this is not beta, this is alpha subunit. It peaks at around 60 to 70 days and declines till a plateau is reached. So this peaking is around 60 to 70 days and it is not raised throughout pregnancy, it declines after the first trimester. So going through the question, HCG is produced by syncytial trophoblast, yes. Alpha HCG is similar to LH, FSH, yes. Doubling time is 48 hours, yes. Peaks at 60 to 70 days, yes. And remains high till second trimester, no. It remains high till your first trimester. Okay, which is not correct about the biophysical profile. Now, biophysical profile is assessed by the Manning score, mnemonic of which is B-MAN. So, in this we are assessing 5 parameters. B is for your breathing movement, body movement. M is for your muscle tone. A is for your amniotic fluid volume and N is for your NST. How is it interpreted? If the score is between 8 to 10, it is normal. If the score is 6, then we suspect that the baby can be in chronic asphyxia. But if it is less than 4, then it is a bad prognosis. Then we strongly suspect chronic asphyxia. So coming to the question, it includes breathing, movement, tone, AFI. Yes, it includes B-MAN. So it is there. Can tell us about the fetal outcome and fetal pH? Yes, it can. Score less than 4 or a pH less than 7.2. 7.2 is suggestive of fetal acidemia. So yes. Score is inconsistent with fetal pH. No, score is not inconsistent with fetal pH. In fact, it is consistent. What is modified biophysical profile? So modified biophysical profile is MAN. This is modified. It assesses only two things, amniotic fluid index and NST. It is said to be abnormal if the AFI is less than 5 or NST is non-reactive. Now, why did we come out with the modified biophysical profile? Because it used to take a lot of time to do the main biophysical profile. Only if there is some problem with the modified biophysical profile, then we confirm it by the detailed biophysical profile now. Okay. So the screening test for a decreased fetal movement is your modified biophysical profile because it takes lesser time. The second best is your non-stress test alone. But what is the diagnostic test? So diagnostic test is always the detailed biophysical profile. What is seen in trisomy 21? Lots of confusing options are here. So let's go through the chart. Quadruple screening, what is it assessing? It is assessing 4 things. A is for alpha fetoprotein, B is your beta HCG, C is your unconjugated estriol, and it is assessing inhibin A. A or B? A, because A is for a quadruple, A is your inhibin A. Now remember only 2 things. Trisomy 18, everything will be low. Okay, everything is going to be low in trisomy 18. Trisomy 21 is Down syndrome and it is a bad prognosis. Okay, so D is your Down syndrome, B is your beta HCG which is high, A is your inhibin A which is high. So just remember 2 things. In Down syndrome, your beta HCG and inhibin A are going to be high. Neutral tube defects, we all know that maternal serum alpha fetoprotein is raised. So friends, this is what our option is going to be. This was all about 30-30. Let's see you in the next match.